so vertical shear and SI joint, I have combined them together because vertical shear involves an SI joint is subluxation and also the sacral fractures. So remember, the SI joint is not crossed by any muscle, and all muscles blend to form these posterior sacroiliac and the anterior sacroiliacs like this. These are the anterior sacroiliac. From here to here, there is no muscle as such. When do SI joint open up? In APCs, in lateral compression in type 3, and in vertical shear. So vertical shear fractures are those which happen when you fall from height and you fall on one leg. The other hemipelvis, because of movement, just continues going up. So that's how it happens. If you have, as I said, the indications are more than 5 to 10 millimeters. And why it is this big? Why do we have this? What will happen if we do not operate? Most of the patients will complain of posterior pain if your displacements are more than 1 centimeter. And I can tell you the patient of pelvis malunion has the worst sort of pain. He cannot stand, he cannot sit. They have a lot of psychological problems later on, and the number of suicide rates in them is very high. So remember, it's not a simple problem. They have a lot of severe pain if you do not fix the posterior part of the pelvis. For both vertical shear and for SI joint, the treatments involve these two methods, which is the iliosacral screw and the SI joint plates, which I showed you. Now this is a case which I showed there. You can see SI joint is opened up and it is having pubic rami fractures also. Now if you look at this, you can see the SI joint is completely disrupted. If you look at APC2, which you were discussing, the posterior SI joint, see this side and see this side, how big it is opened up. So this is a complete hemipelvis which is moving up and down. It is difficult to differentiate between APC3 and vertical shear because both of them are rotationally and vertically unstable. APC3 and vertical shear fractures, both of them are rotationally unstable and vertically unstable. Okay? So how you will fix them? This is an SI joint injury, this is going vertically up. So how will you fix it? You put in a iliosacral screw. You put in the screws, as you see, 2 screws in S1, 1 screw in S2, and then the front pubic rami was fixed with 1 more screw. And this is his follow-up after maybe 6 months or 1 year. You can see that things are uniting in the front. Sometimes you need to do SI plating also for the vertical shear. And I was showing you previously also, you take the lateral window, go from the posterior side, this is the SI joint which is opened up, this retraction is on the sacrum, this part is the ilium. You reduce it first, as you see here it has been reduced. How do you reduce it? You push in a ball point, use a sham spin on the iliac crest, and then you put in the 2 plates which are perpendicular to each other. So in this, if you see, one plate is put down and the other one is put up. want to put in the plates for the vertical shear, you put in one plate here, lower down, and then you put in the other plate like this sticker on the top. Both the plates are at acute angle to each other, around 80 degrees to 90 degrees to each other. You do not put them parallel. You put in one plate, the other plate is also like this. You do not put the plates parallel. If you put the plates parallel, that means both the plates are put like this. When axial loading happens, the two plates start toggling. They go up and down. So that's why you need to put two plates at an angle to each other. That is important. You cannot put in two plates parallel to each other because it will lead to toggling. You can tell them this one.
Cái mạnh tức là khi là bắt cái nẹp của cái gốc dầu sao thì bao giờ bắt xong sẽ bắt xong khi mà nó đứng lên đi thì nó không được, nó sẽ lên nó sẽ không vững. Ở trong đó thì phải bắt thành cái hai lần nhận phân kỳ giống như vậy thì nó sẽ vững hơn.
This is an important thing because I see many cases where people put them parallel to each other and then it fails. As soon as the patient starts walking, they fail because it is acting as one plate. The second thing to note if you are putting in this is only one screw goes in the sacrum. On this sacrum, only one screw goes. You cannot go right up to here. If you go here, that red line which I am showing, that's your L5 nerve root, which controls your ankle.
Và nhớ là cái chỗ này các bạn biết nó có cái để lưng thăng á, để ra mình không thể đứng sâu được, mình nếu mình đi sâu quá, vô quá thì bắt thì chỗ này nó có để thăng thì sẽ làm tổn thương và gây ra liệt. Mà liệt cái chỗ này thì nó chậm vào cổ. Một số anh thì bảo rằng là cái chuyện này là chuyện bình thường chứ không phải các bạn nhé, không phải là điều bình thường mà bất thường. Một số anh xem rằng là khi mà mổ cái này sau mổ xong bệnh nhân có liệt chút xíu là chuyện bình thường hay gặp, nhưng thực ra là với những cái cách gọn này thì mình vẫn có thể đánh được bình thường, bởi vì cái liệt chỗ này rất là lâu hồi phục, cái từ trên này đi xuống tới chừng lâu lắm nha các bạn. Và đặc biệt nếu các bạn đặt hai cái là cái nẹp mà hai lỗ nữa thì cái nẹp nó chồng lên trên cái thần kinh nữa thì các bạn là kết hợp xương với thần kinh luôn thì tim. Nhớ vậy, không phải là đó là một người.
So this is another thing which you need to see, the L5 nerve root, otherwise the foot drop will happen. Many a times, initially, it is easier to do the anterior plating because you open up the lateral window, so you can see that and reduce the fracture and then put in the plate. In my first 10-20 cases, I was doing the plating. Then I learned how to put in an iliosacral screw, and then we went about putting the screws. How do we reduce it? You can use the shank spins. So you put in a shank spin here, or at the supraacetabular region, and pull it out so that your SI joint comes into position. You can also use traction at 45 degrees and try to fix this as early as possible. If you do not do that, the paraspinal muscles pull that up and it is difficult to reduce it. Sometimes the same method, I have shown you this 3 times now. Once in the posterior column, putting in one screw up, one screw down and reducing it. In the symphysis, putting in one screw here and reducing it. And putting it here, one screw in the sacrum, one screw in the ilium and reducing. So you put in one screw on the either side of the fracture and then compress it, and that's how you can get the reductions. So you do this in this fashion. Then comes crescent fractures also, which are also something similar to SI joint injuries, which are a LC type, which I think was covered before. It is known as crescent because of this picture. You see this fragment, which is stable fragment, and this fragment, if you mark it out, it will appear as a crescent, half moon or 1/3 of the moon, the lunar calendar. So that's why it is there. It has an SI joint dislocation and a crescent fracture. And this is the crescent which you see. Again, if you do not fix the SI joints, it will lead to arthritis, which will cause problems. So again, you can put in the crescent fractures through iliosacral screws. These are the type 2 and type 3s can be put through iliosacral screws, whereas the type 1s, which are higher, you put it with anterior plates. Now this is a crescent fracture here. You can see that. You can see that crescent here. So you fix it with the SI joint plates. These are the movements going into the sacrum out here. I am opening this up, putting in 2 long plates as I showed you in this. One plate here, one plate here, and we are fixing this with these 2 plates. So that is how you fix your sacroiliac joint when it is fracture dislocation. You can also fix them with plates from the posterior side, like this. From the back, you can put in an LC2 screw. And the third ones, you put in an iliosacral. Sometimes you have some rare fractures like this, where the bone forms onto the sacrum on the top of it, where again you need to reduce it and put in the screws both in the SI joint ways. So this is the LC2 screws and these are the SI plates. Here you have a fracture which is having, can anybody explain to me what is this fracture?
Bị ép hai bên.
So what classification wise, which kind it falls into? Picture. It's a book, classical book picture. Textbook picture. Take a photograph, put it into ChatGPT, you will find everything out here. This is a classical LC3 fracture. In a LC3 fracture, somebody hits me here. So my hemipelvis goes into lateral compression on one side, type 2, which is a crescent fracture. And then, because the forces continue, my opposite side has an opening because the forces are continuing from here. So So they continue here, and on my opposite side opens up like an APC engine. So compression here on one side, the forces continue from here, and my opposite side opens up because of the forces continuing, and it is causing
Bên mà nó nén
APC
trước
on the
sau đó
other
nó
side.
tiếp tục nó
So
có
crescent on one,
7 cái nữa.
which is NC fracture, and the forces are continuing from this side going on to the left side, pushing the left side out, causing anterior-posterior opening up, which is known as LC3 type of fracture. So one side lateral compression, other side APC is an LC3. Just like in brain, you have a coup counter coup injury. You hit here, your opposite side brain gets damaged. The same way here. You hit here on the pelvis, the opposite side opens up and causes anterior-posterior compression. Inside,
nó giống như cái một cà cú ở bên sọ não đó. Tập chỗ này mà không phải máu bụng đây thì mà máu bụng bị, nên các bạn nhớ thì cái cơ chế thì bên phải thì nó chỉ compression nó kỹ liền, còn trong cái bên trái thì nó làm mở cái sách ra, thì nó làm cái tổn thương đầu toàn bộ phía sau. Và vậy thì các bạn thấy mặc dù cái cảm giác là cái bên trái nó sẽ đông, tại vì nó bị bong từ rất là sao thế cho nên nó bị xoay, mình cảm giác là bên kia là nó nhỏ, mình tưởng là xuyên đông, thực sự là cái cơ chế kép và cơ chế kép ở bên phải, cơ chế kép như là kép.
okay, so some more things out here which I would like to tell you. You see, everything which happens in a pelvic injury, it is not only bones, it is ligamentous injuries. You see the pubic transverse processes, they are broken on both sides. So whenever you find a transverse process broken, think of posterior injuries. You have these indirect evidence. This is the transverse process here, this is the transverse process here. Both sides you have SI joint injuries. What are these? These. This and this.
Đó là cái gì các bạn? Như bên trái, bên phải là cái gì, còn bên trái là cái gì các bạn? Và thấy có một cái mạch xương nhỏ, mà khi cái mạch xương nhỏ mà nó rớt vậy thì các bạn biết là gì rồi đó? Là gì?
Tôi nghĩ là điện báo của cái dây chặt một
Gãy đứt đúng không?
Dạ.
Ok, dây chặt gì nó luôn nghe nó xôm tụ với lại.
bên đây là bên trái là dây chằng cùng dây chằng cùng gai ngòi. Dạ. Bên phải thì em nghĩ dây chằng cùng ụ ngòi, nhưng không rõ bên phải.
So here is the spinous process, and this spinous process has a ligament which goes and attaches to the sacrum, which holds the posterior sacrum together. Okay? So it goes from this like this. And the second ligament is coming from here, going like that. Tuberospinotuberous ligament, sacrotuberous ligament, going like this, and spinosacral or sacrospinous ligament going like that. So whenever your pelvis opens up on posterior side, you will have bony avulsions, ligamentous avulsions. So here it is from the sacrum, here it attaches the sacrospinous ligament. So here it is disrupted from the sacrum. On this side, it has disrupted from the spinous process. Both the sacrum and the sacrospinous ligament is broken. Both the transverse processes are broken. That means iliofemoral ligaments are broken. SI joints are having small plaques. So this is the anterior, and the anterior SI joint ligaments are also broken. So look at these small signs. They tell you how the pelvis is opened up, how the ligaments act on it. So if you get an MRI of this patient, you will find that all the ligaments are broken. Hence you require to fix completely. Posterior, both sides, anterior, both sides. And that's what Sir was showing you that lateral compression NC1, how to check for stability under image. This is also telling you that it is unstable, highly unstable, so you need to fix 360 degrees. Completely you will have to fix. And how have we fixed it? We have fixed it on one side with an SI plate. Opposite side we have put in an SI screws. We have put in a fixator first to reduce it, and then we have put in the pubic rami screws. So here it requires complete fixation, posteriorly, anteriorly, and then you will be able to fix all the branches. So remember, these injuries are important. Both vertical shear and SI joint and sacral fractures, they require either an idiosacral screw fixation or the SI plates. Crescent is coming in LC, but these are your options by which you fix them.
Ở bắt nhíp hai nhíp vô này nè, cái khớp này bắt hai nhíp vô thôi, còn này nó gãy nó mắc vững này, nhíp vô đó được.
Mấy cái ca gãy nhíp